There are a number of risk factors for graft versus host disease, the most important of which is, of course, HLA matching. So the closer the donor and the recipient are in terms of HLA, the lower the risk of graft versus host disease. There are some other factors that we can't control. So the age of both the donor and the recipient is an important risk factor. Gender, both matched and using female donors being a risk factor for graft versus host disease. Things like CMV serostatus traditionally have been considered risks, but probably are less important these days. We also like to look at things like stem cell source. So peripheral blood stem cells have a slightly higher rate of graft versus host disease than bone marrow, which is slightly higher, once again, than umbilical cord blood. Some of these factors we can modify, so we can choose who the donor is going to be and we can choose what stem cell source. But some of these factors are not modifiable by us. We're handed the donor and some of these factors, and sometimes just can't avoid those problems.
When we speak about the overall incidence of acute graft versus host disease, we're generally referring to the percentage of patients who will develop overall grades 2 through 4 acute graft versus host disease, as that's the type that's thought to be medically significant. It's tough to answer that question because if you look at large studies, the incidence varies depending on a lot of clinical factors. And if you summarize all the studies, you can find incidences anywhere from 10% all the way up to 80%. The general rule for a large population of patients undergoing all types of allogeneic transplant is an overall incidence of somewhere between 30 to 40% if you look at large series. In our own institution, we do review our outcomes on an annual basis. For the last few years, our overall incidence of grades 2 through 4 acute graft versus host disease in the first 6 months is right around 25 to 30%.
So when thinking about the incidence of acute GvHD, it's important to remember that it's dependent on a number of clinical factors, including the donor type of the transplant, as well as the GvHD prophylaxis regimen. In the last year, there was a study from the BMT-CTN, a study 1203, which looked at 3 to 4 different types of GvHD prophylaxis regimens. In that study, the incidence of grade 2 to 4 acute graft versus host disease was in the range of 25 to about 35% for all 4 approaches. And that's similar to what we see at our institution at Massachusetts General Hospital. The incidence of acute graft versus host disease at Massachusetts General Hospital, the incidence of acute graft versus host disease is also in the range of 25 to 30%.
Presents with involvement in general of 3 organs only, and we don't quite understand why that is. But the skin, the gastrointestinal tract, and the liver are the 3 most commonly affected organs. The skin is present in 60 to 70% of cases of acute graft versus host disease, typically presenting with an erythematous, raised, or maculopapular rash, often starting on the shoulder girdle, the forearms, and the upper body, and often working its way down. The gastrointestinal tract presents with profuse watery diarrhea, abdominal cramping, and sometimes involvement of the upper GI tract presents with intractable nausea, anorexia, and things like that. The liver is the least commonly affected organ, presents typically with painless jaundice or hyperbilirubinemia, and patients typically do not recognize that early on. It's mainly a laboratory finding unless it becomes severe and the patient is truly jaundiced.